Bismillahirrahmanirrahim. Assalamu alaikum, everyone. Hope you all are good and doing fine and great. My name is Dr. Farooq, and I am the Chief Coordinator and Acting Director of DICE. So today I will begin this webinar, which is on the very great topic of dental emergencies managed at the Chairside. And this session will be facilitated by none other than the Professor Dr. Arshad Malik. So without any delay, I would like to welcome our guest speaker, Professor Dr. Arshad Malik. Assalamu alaikum, sir. How are you?
Hi, Sam. Thank you, Betty. Thank you very much.
So he is currently the Dean of HPS Dental College in Islamabad, as well as the Vice President of Sector Asia of ICT International College of Dentistry, and he's also the Regent of Pakistan as well as Afghanistan. So, sir, you can take from here.
Thank you very much, everyone present here, and thank you, Farah, for my introduction. Actually, this seminar is being arranged concerning that we basically used to face the emergencies in dentistry a lot. And the certain people, especially I'm talking of the new graduates, they are not aware of the dental emergencies. And these emergencies actually, they used to occur. These days, I am Dean of HBS Dental College, Islamabad. I hold the few post, that is Vice President of International College of Dentists. I'm Regent of Pakistan and Afghanistan, International College of Dentists, Section 15, Region 24. These are the president, remain President of Pakistan Dental Association, Chakwa, and country representative of World Laser Federation. I'm thankful to the Society of Oral and Maxillofacial Pathology that they have made me the President Emeritus. Ladies and gentlemen, just simple introduction, and our topic is prevention and management of dental emergencies. Just to see what is emergency, a serious, unexpected situation requiring an immediate action. This is an unforeseen combination of circumstances or the resulting state that calls you for an immediate action. Now, this emergency has two parameters. One parameter is that you are just having an emergency with reference to physical, and second is the life-threatening. These two actions actually both need your immediate action, and that is what the emergency you are going to face. Always in dental surgery, the students and the house surgeons, sometimes they are not aware of that. So this is the main parameter you have to go ahead. General medical emergency which we used to face is hypersensitivity reactions, chest discomfort, respiratory difficulty, and altered consciousness. When we are talking of the hypersensitivity, this is a state of altered reactivity in which the body reacts with the exaggerated immune response to a foreign agent. This may be just simple damaging or uncomfortable, but it may lead to sometimes fatal consequences. These reactivity, actually, the main thing in this is the anaphylaxis. Anaphylaxis is without protection. Ana means without, phylaxis means protection. This is acute multiple systemic allergic reaction involving the skin, airway, vascular system, and GI. Ladies and gentlemen, when you are talking of the multiple allergic reaction, that means you are involved in the multiple organs as well. The anaphylaxis is simply defined as serious allergic or hypersensitive reaction, that is type 1. You know that there are 4 types of allergic reaction, but this is the first type 1 where the histamine is released, and a histamine by the degranulation of mast cells, which rapidly innocent and may cause that. So the anaphylaxis should not be taken lightly. When we are talking of the sign and symptoms of the anaphylaxis, it starts simply from the skin. First itching, then you will feel the flushing of the face or the visible part, then it's converting itself into urticaria. This urticaria and the certain area becomes swelling and blister-like appearance sometimes occurs. While we are on the eyes, it starts from itching. Then you see there is the tearing, redness, and swelling around the eye, and sometimes it's so swollen that you are unable to see even. When we are talking of the sign and symptoms of anaphylaxis regarding nose and mouth, starts from the sneezing, then it is severe runny noses, may be resulting in nasal congestion, and the main thing in the oral cavity is the swelling of the tongue, and with reference to that, sometimes epiglottis as well. And there is metallic taste you will see in the oral cavity. When we are talking of the lungs and throat, this is a very important sign and symptom that when you see there is, in starting, you will feel difficulty in the breathing, which results slowly coughing, and the patient report to you with a chest tightness. And after this tightness, the wheezing starts, and there is a wheezing sound or sometimes coughing sound with loud sounds used to appear. The mucus secretion increases, and that results into extra coughing and spitting. Throat swelling and itching starts, and patient says that my throat is being congested. Then there is a change in the voices. You will see the hoarseness sometime and sensation of choking. Patient said that, sir, I cannot breathe. And that is the thing where you have to face the difficulty in what you say respiratory whole system. Then we will guard for the sign and symptoms of
Sir, your mic is mute. Sir, your mic is muted. Sir.
It is now okay?
Yes, sir. Okay. Sir, it's okay.
We are at the lungs, and I said that when the sensation of choking starts, that become very annoying for the dental surgeon, especially when you are on the dental chair. Heart and circulation, you feel dizziness in the start. Soon it results in weakness, and after that you will see the fainting. This fainting is very alarming. It is whether due to hypotension, maybe due to hypertension, rapid and slow irregular heart rates, and that low BP is a very important, especially when the patient is fainted. So these things, especially check of the BP and pulse and vital signs in these cases is very important. Now, digestive systems start from just nausea. In the initial stages, nausea may lead to vomiting, severe cramps, and immediate diarrhea. And that is a very severe response when you are on the dental chair and patient demands a rush to the washroom. And that is very important. You must be aware of that this is something which is leading to anaphylaxis. In nervous system, start is an anxiety, then is confusion and sense of impending dooms like patient response, and that is very important. Ladies and gentlemen, and we used to see that what is the lab investigation? Lab investigation is the tryptase protein. Generally, you have no time, especially when there is anaphylaxis, that you are going to have this test immediately. But the rise of the histamine, it is just available within 10 minutes that you can get the evaluation and remains elevated for the 30 to 60 minutes. Now, this histamine evaluation and tryptase protein evaluation, certainly it is very difficult when you have anaphylaxis and you cannot have the time that you are going to have the laboratory investigation. Now, the treatment, the patient, you have to go for the series. Place the patient in Tenderberg position. You well know Tenderberg position is the head side down and legs above in the dental chair. See the airway and try to establish the airway as easy as you can. It is the prompt that you have to see whether the respiration is going on there or whether there is any difficulty in the respiration, there is any involvement of the respiratory system, especially which we have discussed before. Give the oxygen via nasal cannula needed. Initial stages, you don't need to have any endotracheal or any oropharyngeal airway. Then you say the target above the reaction site. That may result that as you are not placing the so tight that the vascular supply should be reduced for the time being, but it should not so tight that the blood supply to the body on that area. Say you have given the injection in the arms and you get the an injection. So just above to your arm, you just start giving a torque just above the arm. Epinephrine at the site of the antigen injection, just beside to the injection subcutaneously, epinephrine is very valuable because it start reducing the antihistamine histaminic reaction. That means that the degranulation of the mast cells stops. Now, with the this treatment, then you have the broad concept. One is Benadryl. It is H1 antagonist. It should be before you in the dental clinic. Then is the Tagamet, which is H2 antagonist. And third is the corticosteroid. You can inject the corticosteroid either in the form of hydrocortisone or in the form of prednisolone, and especially in case of anaphylaxis, you are permitted to give the ultra short acting type of anaphylactic medicine, like you can say Solocartif. And this Solocart, at the 250 milligram for the adult, you can give in anaphylaxis very safely. And according to the body weight, you have to sometime measure it. Now, after hypersensitivity reaction, if any person has a question, he can raise the hand so we can move forward. Yes, any person who has the question regarding chest discomfort, hypersensitivity reaction, I can answer. Hypersensitivity reaction, if any person has any question, I'm here to answer before proceeding to chest discomfort.
Because you guys can ask sir by raising hand or like unmuting yourself, or you can ask in the comment chat box as well by typing your question, because it would be like great thing if you make it interactive session. So sir,
Yes, I'm here just to give you the answer in a very activated.
so there is a one raise hand. किसने raise hand किया? Kindly अपना question मुझे आप
Question करें बेटे, कौन है?
जी सर,
Please.
Dr. Ahmed Iqbal.
Any question regarding to hypersensitivity reaction? Because we are proceeding forward.
So Dr. Ahmed
We are
Iqbal,
proceeding
you want to
forward.
ask question? जिसने भी raise किया मुझे kindly बता दें, तो मैं उनका question बता देता हूँ सर को. If you have, you can let us know.
If not, then I can move forward.
Yes, sir, you can proceed. I think, and no one has any question. So,
okay, thank you. So, the chest discomfort is also very important thing on the chair side. Hypersensitivity reaction you can observe within seconds, but chest discomfort generally used to appear. Sometimes it used to take time. Yes, the chest discomfort. My request to admin is that whatever you see any person disturbing, just get him out from the participant at once without any delay. And if I have to stop the conversation for the time being, no matter, I will stop it, but remove that person from the chat box.
sure, sir. Sir, we are like left with 10 minutes. So after guys, this is a recurring meeting. So do join after 10 minutes again if this session ends here. Okay? So sir, you can proceed now.
Yeah. The chest discomfort. Before going for the detail of the chest,
Sir, mic is unmuted. Kindly unmuted.
yes, it is there.
Yes, sir. Not fine.
So, chest discomfort. First, we see this. What is the in the chest? Right, starting from the esophagus up to the diaphragm. You can see in the chest. The origin may be skin, maybe muscles, maybe from the bone. It may be from any joint. In the vicinity of the chest, heart and vessels, lungs, airway, esophagus, and neural in the region as well. So for these chest pain, you must have the power to distinguish between that what type of the pain it is, and you have to separate from other differential diagnosis. The chest discomfort generally from the cardiac of the chest pain, respiratory causes of the chest pain, vascular causes of the chest pain, GI causes of the chest pain, and musculoskeletal causes of the chest pain. If you see at the cardiac causes of the chest pain is either in the form of angina, either in the form of what you say MI, myocardic infarction, and pericarditis. Now, what you see in the angina, it is a typical distribution. It is exertional. The patient, if exert certain labor, walk in the your clinic is in the what you say in the upstairs, and this upstairs clinic, the patient move up, and it is what you say, it is exertional. So what will happen that this will result into angina pectoris. When we give the rest to this patient, the automatically angina get released, especially when you are taking meals and in the cold weather. So if the dental clinic has the cold atmosphere, especially in winters, and the patient has just taken the meal, the angina possibility is more. Then is accompanied symptoms. It is generally relieved by the rest, and you will see that the meal and cold weather, when you give the protection to these two things, that ask the patient that patient should not take extra meal or heavy meal before coming to dental clinic, or if it is taking the light clothing, especially in winter, then it may be precipitating angina. There may be accompanied symptoms and relieved by the rest are GTN, that is glycerin. I will discuss in detail the management. Myocardic infarction, actually, it is slightly more, and if the angina persists more than half an hour, then you automatically understand that this is not the myocardic, not the angina, but it's the myocardic infarction. The severity is more as compared to angina, lasts longer, say more than half an hour, then it is definitely myocardic infarction. Tightness and heaviness in the especially in the chest area, and there may be the patient choking and constriction in the chest. Patient used to say that there is something going on in my neck. Anxiety, fear of impending death. He will ask you, sir, I'm going to die. I'm going to die. Please do something to me. That is a clear-cut myocardic infarction episode. Vomiting, collapse, syncope, and patient become silent, and that silence is really a big life-threatening one as well. Ladies and gentlemen, these are the areas related to cardiac problems, typically distribution on and referred to the left side. And you see the very important thing is the lower part of the arm and the small two fingers, they are painful. Your thumb and index finger and second finger, they are not painful. And above part of the deltoid is, and the below part of the arm is painful, not the above. This is a very specific one, and the chest hole, front and side, and maybe extending to the chin and mandible and even to the front of the ear. This is the typical related chest pain with it has the identity. The in front you can see like this, and in back you can see that it is like spreading to the areas which are very really in the vicinity of chest. The heart attack is another important thing which you see in your clinic. The starts from the shortness of breath. Here you must become alert. As soon as the chest pain starts, there is a severe vomiting and nausea response. Patient is in severe anxiety, sweating, dizziness, and then a patient is going to collapse. These are the steps which you have to see in the symptoms of heart attack. Sorry. Now, heart attack is the phase in dental clinic where you must not have to place the patient in tenderberg position. It should be upright position. It should be at the 45-degree, calm and quiet area, not distorting more. You are going to ask the patient when there is symptoms of heart attack to cough more. This is very important and everybody should understand it, that whatever you have doubt that the patient is going to have the heart attack, you are not going to have the patient just relax. You have to ask the patient to have more coughing. This is the maneuver which is required at that time, because you are going to stimulate the heart for its pumping and especially for its oxygenation. If you are going to ask the patient to relax or turn, the attack episode will be exaggerating. Now we are coming to respiratory cause of the chest. If any person has any question with reference to cardiac cause of the chest pain, he can ask the question.
Sir, just we can like start this after 1 minute, because we have just only 1 minute left, and this meeting will end, and after 1 minute the new meeting will start. So you guys can join back on the same link, okay? Because this is a recurring meeting, and if you have any problem, you can also WhatsApp me, and then I will share the link again. So आपने दोबारा आना है इसी लिंक पे, ठीक है? हम बस 1 मिनट बाद दोबारा 10:24 और 10:26 या 27 तक दोबारा हम स्टार्ट करेंगे, तो आप लोग फिर काइंडली इसी लिंक को ज्वाइन कर लीजिएगा, ठीक है? ठीक है सर?
Thank you very much. It is my request to International College of Dentists head office as well, that this is a recurrent meeting, and we are going to stop this meeting just now, and we are going to restart within error of seconds. And just all the people in international platform, they are requested to please rejoin the same code, and we will write back. Thank you. Just for a while.
And so, sir, I have made you host, so you can like share the screen as well. सर फिर दोबारा मुझे होस्ट बना दीजिए, मैं बना दूँ.
बेटे मुझे जरा बता दो कि
नहीं ठीक है सर, मैं खुद बन जाऊंगा. आप बस आप काइंडली ना स्क्रीन शेयर कर लेना अपनी पहले. ठीक है सर, इसको जरा बड़ा करें. अब ठीक है, बेहतरीन.
Whether we start or we wait for the audience to come back?
Sir, just 1 minute देख लें, बाकी आप उसके बाद हम.
Just I am waiting for the audience to come back so that we can.
No issue, sir. ठीक है.
If there are any question regarding cardiac cause of the chest pain, I am here to answer. Any person who has any question regarding cardiac cause of the chest pain, I am here to answer.
फिर पूछना चाहता तो पूछ ले. बेशक अपना माइक ना अनम्यूट करो, चैट में लिख दो क्वेश्चन, से बता देंगे आपको.
Sir, may I speak?
Yes.
Yeah. Please introduce your.
Sir, my name is Dr. Abdul Mueed. I'm from Faisalabad. Sir, मैंने actually ये पूछना था कि sir कार्डियक कॉजेज में हम नाइट्रोग्लिसरीन का कितना यूज और किस किस टाइम पे हमारा यूज फायदेमंद होगा? और सर क्या हमारे रिक्वायरमेंट में ऑक्सीजन और इस तरह की मतलब चीजें जो फॉर एग्जांपल
yes,
मायोकार्डियल
मोहित मैं आपका समझ गया डोंट वरी आई एम गोइंग टू एक्सप्लेन एवरी स्टेप how to use the nitroglycerin in coming slides inshallah you will see just I'm exploring the chest discomfort not going for the management at the end I am going to give you the detail of management don't worry
जी सर got it sir thank you
so we move forward in the respiratory cause of the chest pain. Yeah. Respiratory cause is just three. You will see any pulmonary embolism, and that results into severe chest pain. Tension pneumothorax, that means anything within the vicinity of the chest and lungs, this which is creating pressure to the lungs, whether in the form of liquid, whether it is in the form of air, and then is pneumonia. Patient is already is under the influence of the pneumonic problem, and the patient may report to you with the chest pain and has no relation with your dentistry, but already existing these causes may result into chest pain. When we are talking of vascular causes of the chest pain, it is very much there. Thoracic aortic distension, which is maybe either developmentally or either maybe due to certain medicine. If it is there, that the patient may refer to you. And in sickle cell anemia, there is also the chest pain. Now, when we are talking of the GI cause of the chest pain, that is esophageal reflexes, especially in the patient with the regurgitation and the especially with the patient having hyperacidity and an peptic ulcer, and these people have the esophageal reflexes which results into chest pain. Esophageal rupture, whether it is by the trauma or whether it is by any type of disease, may result into chest pain. Pancreatitis, it is a very severe type of episode, sometimes may leads to the chest. And a peptic ulcer, obviously, all the peptic ulcers, they cause severe pain in the chest and its vicinity. So for these purposes, you have to go for the differential diagnostic. You have to check all the history of the patient. And if you are smart enough, you have the good examination, and especially the patient physician can help you a lot. Then is the musculoskeletal cause of the chest pain, and that is the osteochondritis, especially in the mid, and that mid results into a severe sometime condition, that is the muscular pain, and you are confusing sometime with the other thing, and that is the patient history sometime gives you a very good indication. Trauma, especially in a roadside accident or previous trauma, even sometime after many years, yet the patient has the pain because sometimes there is a trauma on the chest mid and the chondrium is fractured, the especially cartilage is fractured, and that may result into sometimes severe trauma even after healing. So after getting this concept, I'm already, Dr. Moeed has asked me regarding the management of the chest discomfort in dental office. Now we are going to have how you are going to manage the patient with the chest pain. Number one thing is you defer all the dental treatment. In this position, when there is chest pain, you are not going to have the tenderbar position. That means the head side down and legs above. This is not indicated in chest discomfort patient. You have to make the patient in semi-reclined position. That is approximately at the degree of 45 to 60 degrees. Give the nitroglycerin about 0.4 mg tablet. Separates in many countries they are available, and in some countries they are not available, but the tablet of nitroglycerin is always available. then you are going to administer the oxygen. Don't go for the administering the oxygen with the pouches, or just you give the nasal slit, and you just place the oxygen in the initial stages. Don't give for the ambu bag or like this. This is in the initial stages. It is just required that you are placing the oxygen to the patient. Just the pulse and the pulse, especially the blood pressure. These are related to the vital signs, and that is very important. The pulse should be within the limit of 72, and you must be very alert when it is above the 100 or 110 or 115. That is the very alarming one. Blood pressure, you have people know 120/80 is the standard. For the patient, when it is raised above 200, that is systolic, above 1. And if it is above to 100 in diastolic, that is very alarming one. At this stage, you are not allowed to have any type of oral surgery. I will say that oral surgery in hypertensive patient above to 85 is just a challenging one. And above to 90, I don't think that it is recommended. And above to 100, it is really a drastic insult, and you are going to face the severe consequences if you are going to have the diastolic more than 100. And systolic, if you are moving above to 200, then that means you are going to have the consequences of post-operative bleeding. Even during surgery, you may face the difficulty. Now, if you have done this maneuver and the discomfort is relieved, that means you can assess that this is the attack of the angina, and you have just given the 0.4 milligram tablet of the trinitroglycerine, and the patient got relief. Now, slowly taper the oxygen within the 5 minutes. Don't remove it at once. Just slowly relax the patient and come to the atmospheric air. Modify the dental treatment to prevent reoccurrence. Modification of the treatment means that you are, you are doing in the initial stages slightly aggressiveness, or the instrumentation moving in an aggressive way. Now you calm down yourself as well, and your movement and your will be very comfortable to the patient, and your talking and your body language will be more relaxed as compared to before. That is your own modification. Now the treatment modification, especially I will say that if you are going to have the root canal treatment, and root canal treatment, you are just getting the pulp out, and the local anesthetic agent is not effective, then sometime you can have the repeat of local anesthesia, or you can inject it within the pulp chamber or like that, so that the patient should be comfortable before. That requirement is there. But if unfortunately patient discomfort continues after 3 minutes, no, I'm saying 3 minutes. You are not going to wait more than that. After 3 minutes, what you are going to place the second dose of trinitroglycerine and monitor the vital signs. These vital signs, you well know, that is respiratory rate, that is your blood pressure, pulse, and temperature. These are the 4 vital signs you have to check for that. And if you see that after 3 minutes and you are giving the second dose, the discomfort continues. Now, ladies and gentlemen, try to understand. First, there is chest pain. You have given oxygen and trinitroglycerine. If not improved, you are going to give after 3 minutes the second dose of trinitroglycerine. And after 3 minutes, if the yet do not appear, and second dose, you are going to introduce the third one. This becomes the 9 minute. Yani within 10 minutes, you are going to place the third dose. Give the third dose of the trinitroglycerine. Monitor the vital signs, and hence summon the medical assistant. You can make it don't be sophisticated at that time, and don't be what you say, resistant to calling any person. You can loudly say, anybody there, anybody there, like this. This is your sound, and this is actually required at that time. Don't be shy, or don't be because it is the time that you have to call someone for your what you say, emergency. Now, if this third dose going to result into relief, refer the patient for the medical evaluation, and before you are going to start any further treatment. And if God forbid, after the third dose, you are not going to get the relief, what you are going to get? No, you are going to assume it as myocardic infarction. Ladies and gentlemen, try to understand it, that you have given first dose of nitroglycerin, you have given the oxygen, you don't get the relief. You are going to get the second dose after 3 minutes, you give the oxygen continuously. Then you are not getting the relief after 6 minutes, you are going to introduce the third dose, and within 10 minutes, you see there is any relief of now. Giving three doses of the trinitroglycerine within 10 minutes and the oxygen, if you are not going to get the relief, that means it is myocardic infarction. What a simple thing to understand the myocardic infarction. If after the third dose it is relieved, then you can understand it may or may not be myocardic infarction. But if in the second dose you get the relief, that means it is angina pectoris. It is not the myocardic infarction. This is a very important thing to understand, especially when you are talking about. Assume the myocardic infarction after the third dose, and you administer the 325 milligram of aspirin. That is very mandatory, especially for the patient who are going to have the myocardic infarction, or you expect that these are myocardic. Then you start drips of the crystalloid solution at 30 milligram rate. Now, myocardic infarction pain is very much annoying, and it is really a very challenging one. In the dental clinic, you must have the morphine sulfate 2 milligrams, subcutaneous or intravenous, and every 3 minutes you can give this 2 milligrams subcutaneous, and even if the severity is there, you can go for the intravenous after every 3 minutes until you get the relief you have. Now, basic life support and transport to the emergency care facility is also must be in your mind. Basic life support, especially respiration, chest congestion, then you have to see the vital signs. These all things must be in your mind while you are going to have the myocardic infarction, the transport, and call for the emergency. That is what, ladies and gentlemen, regarding the chest discomfort. Now, I can wait that any person has now the question regarding the chest discomfort. I'm here to answer you. Moeed, you have understand? If there you could not understand, can you can ask anything?
No, sir, I've understood. Thank you so much.
Thank you. Anybody else? Anybody else has any question regarding chest discomfort? You can raise the hand and you can speak. So we move forward. That is respiratory difficulty. Now the patient is on your chair side, and the patient giving the respiratory discomfort. This discomfort is related to all these 5 parameters: either asthma, hyperventilation, chronic obstructive pulmonary disease, that is COPD, foreign body aspiration, and gastric contact aspiration. We take it step by step. Asthma is the persistent recurrent current episodes, and especially with the shortness of breath, that is the dyspnea, and wheezing sound. It is a shoo, wheeze. This is a wheeze. You just go for the auscultation and place it in a, you will see a wheeze type movement coming, going, coming, going. And that is especially giving our chest tightening symptoms. As the time passes, these symptoms become more and more aggressive, and you may have all the above symptoms at a time. So persistent dyspnea, wheezing, and especially chest congestion. The triggers of the asthma may be extrinsic and may be intrinsic. That is intrinsic with relation to the mold, certain foods, pollen, dust, and especially animals, especially with reference to cat hairs or like that. Non-allergic triggers may be infection. The patient has the infection, and due to these infections, the patient has got the asthma. Emotional or stresses may lead to asthmatic episodes. So that's why it is called that your dental clinic should be very comfortable and should be very promising atmosphere. That patient should not be intense. Medication, especially I am saying of the aspirin, may cause sometimes asthmatic attack. Exercises, if the patient is already under the influence of the asthmatic attack, then if the patient go for the stair climbing or moving fast, may get the asthmatic. Air pollution, and especially when there is any, you see your compressor is there, and if your compressor is producing fumes or any type of dust or like this, the patient may get the attack of the asthma. In the sometimes the perfumes may result into the asthmatic attack, especially in dental clinics. Sometimes you go for the perfumes as well. Fragrance, chemicals, and sometimes the occupational irritant, it is also there. Now, when there is acute asthmatic attack in the patient, how you are going to manage? Terminate all the dental treatment, position the patient in fully sitting posture, never ever in a lying position in asthmatic. You are going to have the more chest concession, because when you go for the Tenderberg position, the diaphragm is being pushed more and by the contents of the abdomen, and the chest size is reduced. So it is advised that always get the patient in sitting position. Patient has always thirst of the air and used to rush towards the door, and that is the main time when you are going to administer the bronchodilator in the form of spray, or then if you have the oxygen, please give at once the supply of the oxygen to the patient, because the lung is thirsty, and you supply the oxygen. Monitor vital sign, like that I have requested that whenever there is any emergency, you are going to have the monitoring of the vital sign.
Sir,
If
there is a question. What is Tenderberg position? Dr. Osama has asked.
Tenderberg position is that this is a common position which we used to have during syncope, or when the patient is but it is not in the straight position. We ask the patient to lie down on the legs are above and head is down, and that is called as the Tenderberg position. That you favor the supply of the head and you raise the legs. That is the reversal of the vascular supply from the periphery toward the cerebral flow, because it is due to the gravity, the blood used to flow more towards the cranium. as the legs has the all the veins without any valves, so valves are open and the blood supply toward the brain is increased. That is called tenderbar position. Sign and symptoms, if they are relieved, you monitor during the recovery in the office, slowly taper the oxygen in the 5 minutes. I am again saying that if you are going to give the oxygen in the emergency, it is better that when you are going to discontinue the oxygen, not discontinue at once, just slowly give and relieve, give and relieve, and slowly you omit it. No further dental treatment till you get the approval from the physician, because you may get the episode again. I'm sorry. If the sign and symptom continues, you give the epinephrine. It is 0.3 ml in subcutaneous, and you can start the IV line of the crystalloids, especially but if the sign and symptom continues, you are going to give the epinephrine subcutaneous or intramuscular, start IV line drip for the crystalloids, and monitor the vital sign. Yet after this maneuver, the sign and symptom do not relieve, then call for the medical assistant. Start the theophylline, especially in 250 milligram. It's a very clear ampule, and you give IV, and you can give the cortisone 100 milligram IV as well. Now, you always defer the treatment, and you call for the emergency, recall and refer the patient to the emergency facility. Any question regarding asthma? Sorry. If no, I can move to hyperventilation. Hyperventilation is already the person under stress. That may be all these factors regarding unemployment, work stress, illness, chronic, or for ladies, new baby fear, new job, health problems, griefs, bullying, and divorces, and these all things results into hyperventilation stresses, and these stresses results into the circle of the hyperventilation, feel unwell, then resulting into anxiety, more hyperventilation, it increases the symptoms, then the circle goes on. And if this hyperventilation goes in the dental clinic, your dental treatment, what you are going to do? You take the clear-cut history, and in this history, if the acute hyperventilation is there, you will feel all these agitation, hypopnea, then anxiety, wheeze, palpitation, span, sudden onset of dyspnea, chest pain, tachycardia, neuralgic symptoms like dizziness, tingling, numbness of extremities, dizziness, weakness, paresthesia, whatnot. You can get so many things at all without any specific physiological problem. It is just by the hyperventilation. And the chronic, starting from the chest pain, then dyspnea, neural deficit, pattern of the similar presentation in the past, vivid dreams, dry mouth, sexual or motor problem. These all are related to the patient with hyperventilation, and this is you are going to get from the history. Proper history, it is very mandatory for the hyperventilation management.
सर दो क्वेश्चन हैं, डॉक्टर आयशा पूछ रही हैं, और एस्थमिक पेशेंट अर्ली मॉर्निंग अपॉइंटमेंट होनी चाहिए इवनिंग की?
The early morning, definitely early morning, because asthmatic patient in evening is never ever recommended.
सर एक और सवाल है, साइम डॉक्टर साइम पूछ रहे हैं, व्हाट इज क्रिस्टलॉइड्स?
What is?
क्रिस्टलॉइड्स?
Crystalloids are the chemicals which actually give potentiation to the blood volume and get the nutrition and electrolyte balance in your body. And these are always be present in your clinics, and it is always given in the IV lines to stabilize the systemic, what you say, conditions. Anything else?
No, sir. You can proceed.
The treatment, all the dental treatment, remove all the foreign bodies from the mouth, especially. Position the patient in fully upright position. I have already requested that for the patients with having the respiratory and cardiac problem, you are not going to place the patient on tenderbar position. Attempt to calm the patient verbally. These patients are very, because hyperventilation results into anxiety, and administer the carbon dioxide and rich air as in which out of the small bags, especially here I am going to mention that why not oxygen, because oxygen deficiency is hyperventilation results into excessive oxygen supply, resulting into demand of the exhaled carbon dioxide is required. So at that time, you are going to give the carbon dioxide. So the respiratory rate should be maintained. You are going to monitor the vital signs. And if you are going to get the relief, you are going to perform all the dental procedure, and just you are going to have the anxiety reducing protocol that we have mentioned already. If the sign and symptom continues, then what you are going to give the diazepam. This is especially with reference to hyperventilation. Give 10 milligram diazepam or 5 milligram diazepam. This is available, and you can give it slowly intramuscular and as well as intravenous. Intravenous, if you are going to get better, that you are going to dilute it, and so that titrate should go into body very slowly, and you are going to monitor the vital sign. If you are going to have the hyperventilation symptoms going on, you defer the treatment, and then you send the patient to the family physician. That is mandatory. Do not go ahead after you are giving the diazepam and or midazolam, and you are not going to continue the patient if after this dose you are not going to manage the vital sign and defer it to patient, defer your treatment till the physician gives you the green signal. Now, after hyperventilation disease, COPD, it is generally present after the age of 35 to 40. Patient has a cough and sputum production, and especially these patients are very heavy smokers, and in cold winter these diseases are very common. The history patient will report to you with chronic bronchitis, emphysema, and sometimes airway diseases. Asthma is not included in chronic obstructive pulmonary diseases. Now, for that purpose, what you are going to do, terminate all the dental treatment, remove all the foreign bodies, from the mouth, especially if you have an instrument, you have any probe, any gauzes there, you are going to remove it. Position the patient in fully upright position, as we have already discussed that in respiratory and in cardiac patient, we are not going to have the spine position or tenderbar position. It is always that the 45-degree or 60-degree. Admit the attempt to patient call and asked verbally to satisfy him and give assurance to the patient, administer oxygen at this, especially for COPD, there is definitely due to congestion, due to lungs problem, due to incapability of oxygen carrying capacity of the alveoli, you have to administer the oxygen. You monitor the vital sign. If the sign and symptom relieves, you are going to perform the dental procedure, and you especially with reference to having the anxiety protocol. If you are going to give more excessive oxygen, you are going to have the hyperventilation. For that purpose, discontinue the oxygen, and then you are going to have the just a pause. And if yet you do not get the relief, you are going to defer the treatment, start the basic life support parameters, and then send the patient to emergency, specially oriented offices, and to his family physician for the further treatment. This is very mandatory that up to the level of giving the oxygen, and you are going to having the anxiety control parameter. If the COPD patient do not get relief, then it is better to defer the treatment. Now, foreign body aspiration is another big emergency in the dentistry, and that is big emergency is that you are going to save the life if the foreign body aspiration is there. No, foreign body aspiration, inhaling or breathing of the foreign bodies into respiratory tract. Most object enter GIT tract because of epiglottis seal the trachea, that the objects go to directly to the oesophagus. All efforts should be made to remove the foreign body immediately. Foreign body that is fractured or extracted tooth, broken dentures, distal restoration, crown bridges instrument, RCT files, needles. Now, ladies and gentlemen, the first thing is you always go for the removal of the thing by asking the patient for the cuffing, and especially pushing the hammock position right from the abdomen, and you push the abdominal area so that the diaphragm is pushed up, and so that all the foreign element is cuffed out. If the baby is there, you better that you take the both legs of the baby right above, and you give a choking on the back side of the baby. All the foreign body that is in the throat will come out. Due to trauma, inflammation, and sometimes hematoma may enter into respiratory tract, and infection, especially glossitis, and these foreign bodies may result into dislodgement after because the tongue is not responding permanently. CNS diseases may have certain problem in especially motor nervous system, and the things are just engaged in the throat. Gastric contents, if they are aspirated, they are very much dangerous to your life. The management is that immediately after a foreign body disappears in the throat of a patient, pop up the patient upper part at 20 to 30 degree angle with the head reclined. ask the patient to pull the head down, and on the back, you are going to have the popping. And this popping will result into thrust of the uh, air outside and resulting into removal of the body. Finger sweep the mouth, and that is very important. That way it results more coughing. And secondly, if there is in the gastric, it may results into outside the spitting of the vomit.
Sir, we have only 1 minute left. So again, I would like to say everyone, this is a recurring meeting. So kindly join again after 1 minute. And sir, you can also say this thing. And sir, we have one more question. Someone has
Yes.
asked why diazepam and midazolam? जो previous आप बता रहे थे उसमें वो क्यों देते हैं?
These are relaxants, and especially in the tense condition, when the patient is very excited, and as any stimulation, any anxiety and uncooperation may result into more consequences of these events. So that is important to give the anxiolytic so that the patient cooperation should be maintained.
So, okay. Sir, just 1 minute left. After 1 minute, we will be again joining. Inshallah.
So it is requested to all the national and international audience that we are, this is recurrent meeting, and in recurrent meeting, there's always the limit of the 45 minutes. So it is my request to all the participants that after the time is over, you are requested to rejoin in the same meeting by just clicking on the source. And you are very much in time that we are covering the things, approximately all the things which used to happen in a dental clinic emergency. And especially my request to all the young people is that
so sir, you are host now, you can like share. Okay. Ji, sir, it's visible, and we will be starting like in 1 minute, guys. So if anyone has any questions so far, he can ask, he or she can ask, sir, right now.
yes, if you have because we have time that we can I can answer you. Any person who have any question regarding the previous chapter which we have covered.
Prof, can I ask a question? Can you repeat about the asthmatic patient? You were talking about morning and evening. What is it? Seeing patients in the morning, not in the evening?
Actually, lady, the question is with reference to asthma. You know, sometimes in the chest diseases, the patient is reporting to you with a chronic chest problem as well. The asthmatic patient, they have actually the problem in their parasite because the smooth muscles around the alveoli, they are congested. In the morning, when the patient used to rise, the congestion is there. So the patient generally used to take the relaxant and especially Benadryl or like that medicine, so to expand the chest. In the morning, when the patient comes to your clinic, the patient has taken the medicine, patient is very alert, patient is especially very cooperative in the morning time. As the day passes, the exertion, the tiredness, and the whole day psychological and physiological traumas may result into patient uncooperation. So the immunocompromised patient, and especially with reference to asthma, we prefer that these patients should be managed in the early morning in the dental clinic, because if God forbid any emergency occurs, you have the time whole day to manage it, for the calling of the any other physician or sending the patient to the tertiary hospital or to the more safe hands. But if you are operating this thing in the evening, then it becomes very troublesome for you as well, because you have no time, the night is coming, and you are going to have the closure time of your clinic sometime. And what happened that if you get any emergency at this evening time, you are going to have all the problems of sending the patient to tertiary hospital, and even you don't know when the patient is going to recover. So that results into late recovery time, and that is psychological problem for you as well as for the patient. So it is always mandatory that immunocompromised patient, cardiac patient, respiratory distress patient, asthmatic patient, and diabetic patient, you are very nicely handle them in the morning.
So, sir, there is one other question as well. Someone has asked why we give carbon dioxide to asthma emergency patients.
The asthmatic patient, we don't give carbon dioxide, we give the hyperventilation. The hyperventilation is the control of the ventilatory system. So when you give the oxygen, the ventilatory system is generally exhausted. So we give the carbon dioxide to control the hyperventilation.
Sir, okay, you can proceed now.
Thank you. So we are managing that how to remove the foreign body. You ask the patient to bend the neck 20 to 30 degrees down, and you just pour from the back. Ask the patient to cough as much as can, and you sweep the finger in the mouth. That will also potentiate the removal of the foreign body. If the patient develops sign of complete airway obstruction, you do the Hamlet maneuver. That is very internationally known maneuver, that you stand back of the patient, you put your both arms at the abdomen and pull the abdomen back towards you, and ask the patient to knee down and put the both heads above, and that results into choking, complete clearance of the and ask the patient to go for the coughing repeatedly. Send the patient to the hospital, and finally sometimes you have to go for the tracheostomy and thyroidectomy, and that is a very important thing that you should be aware of. That. So I will rather request that senior people and the young people, they must get the experience of cricothyroidectomy. That is a very simple procedure, and that should be can be managed at the dental clinic. I say that if the severe type of obstruction is there, you have only 5 minutes sometime, and it is absolutely the patient is unconscious. If the patient is unconscious and respiratory blockage is there, and you are in the condition that there is nobody is there to help you, and you are all alone, and you think that there is a hospital is so away that I cannot send the patient to the hospital, and patient is going to die within 5 minutes or 10 minutes, and absolutely the patient is gone, and no respiration, no, at that time, only at that time, when absolutely no any help is there, and you are not expert for going for the cricothyroidectomy or any maneuver surgical, and the obstruction of the air is absolutely there. Take one nail, and put this nail into just beneath the thyroid cartilage and push this into trachea without any fear. Without any fear, just put the nail into that area. If the nail is not present there, you can put the blunt side of the periosteal elevator, sharp side of the, you have the mode number 9, you can push it there. This is the only required when there is absolutely no any help there, the obstruction of the airways there. You cannot have the you are not able to remove the foreign body, then you are going to put the nail right there, and if from here you insert the nail inside, and from here you are going to get the relief. And putting this nail inside, keep it in the hand, the respiration wheeze inside like a shout, and you will see the patient is back. And putting this nail, then you can transfer this patient to the hospital and lie down in the hospital. That this is I have done during this emergency. That is what I have to say. Now, if the patient is unconscious, call the emergency medical service. You must be aware of the basic life support. I have the full seminar on BLS, and inshallah we are going to have the BLS seminar also online, and soon within this month or next month. You place the patient in spine position, head tilt, chin lift, and jaw thrust, so that the respiration will be maintained and the foreign body should be removed easily. Access the breathing, look, listen, and feel. And that is very important, that you are going to look at the chest, whether it is moving or not. You are putting your ear near to the nose, that whether is respiratory sound is there, and then you feel it by the hand, that whether chest is moving or not. And effective artificial respiration if there is a requirement for this. Prevention of the foreign body is very important. Rather than creating the emergency, you remember the best thing is use the rubber dam as well. That is a very protective thing. Use the dental floss ligature to secure small instrument or root pins, and especially patient with the impaired coordination of swallowing and coughing reflexes should always be treated in sitting and slightly reclined position. Do not go for the more reclined position. Removal of the broken prosthesis before you are going to start the maneuver. Otherwise, these broken prosthesis will dislodge into the throat. Now, step by step, first thing, if the patient has the foreign body aspiration in the trachea or the respiratory areas, terminate all the dental treatment, remove the foreign body from the mouth, position the patient in sitting position, never spine position, and ask the patient to try to cough out the subject as much as can. Thank you. Patient remain conscious. Now, the first thing, aspiration is there, that the patient is conscious. What you are going to do, symptom persist. After that above maneuver, you are going to have the start the Heimlich maneuver until the effective and respiration starts. If you unable to ventilate conscious patient, you are going to administer the oxygen. Medical assistant should be called, monitor the vital sign, and for that purpose, better that if the Heimlich maneuver is not effective, better the patient sent to the emergency as soon as possible. If is unable to ventilate, what you are going to do? You are going to ensure that foreign body is there. Administer oxygen, call for the medical assistant for the radiography, perform the bronchoscopy, monitor vital sign, and transport to the emergency facilities. Now, that is sometimes that is actually not possible, that if you are going to have the symptoms occurring right there, then you have to stop the things doing yourself. The administration of oxygen is very important, especially for these people, because the choking is there and you are just going to perform this. But one thing is very there, that all these bronchoscopy procedure is not possible in the dentistry, and so it is better that you refer as soon as possible to the safe area, especially to the tertiary hospital. Now the patient is unconscious. If the patient is unconscious, call for the medical assistance, place the patient in spine position, begin abdominal thrust so that you get the foreign body out if possible. Turn the patient on the side to sweep the oral cavity by finger and remove the foreign body by placing your finger inside, and attempt to ventilate as much as you can. If this maneuver results into ventilation, start the basic life support, administer oxygen, and transport to the emergency facilities area. Unable, then you try to repeat the 6 and 7. That means you are going to sweep the oral cavity and place the finger to remove the foreign body and try to ventilate. And if all the things fails, then you are going to do the cricothyroidectomy. And if I have said that if you are not able to perform the cricothyroidectomy, patient is going to die and you have no place to send it to tertiary hospital, and patient is in the last moment, and if you are not going to give anything, put your nails into cricothyroid just beneath the thyroid cartilage right here, and you are going to put this nail inside. You are going to maintain the respiration. Sometimes people used to say that if you have nothing, you have just pen, you insert the pen inside. So you have to give the path to oxygen to enter into lungs. And that is the very important maneuver which every dental surgeon must understand, that it used to happen not only in dental chair, but sometime at the home, sometime in the even in the public places. There is choking and the person is going to die. This is the last resort that you are going to maintain the respiration. Now gastric contents aspiration, that is the patients sometimes get the nausea and frequent swallowing, feeling of anxiety, gagging. What is tachypnea and wheezing of there, and hypotension and cyanosis is there. These are the signs and symptoms you will come to know that the patient has taken the gastric contents inside. Remember one thing, that the gastric contents are acidic in nature, while the respiratory area is alkaline. When the gastric juices, they enter into respiratory area, they result into lytic activity of alveoli of the lungs. So it is very important that as soon as the patient is recovered, it should be sent to the pulmonologist for the clearance of the lungs, because this acidic pH of the gastric juices may result into very drastic consequences of the respiratory area. Now, if the gastric contents aspiration is there, terminate all the dental treatment like ever, remove the foreign bodies from the mouth, position the patient in right position, in horizontal position especially, and sucking the oropharynx. Vomiting cease, no symptoms of aspiration present, then call for the medical assistant, monitor vital sign for 30 minutes, and transport to the emergency. If the vomiting do not cease, but the symptoms of aspiration are also present there, the matter is very difficult. But the vomiting cease, but the symptoms remain there. You administer the oxygen, call for the medical assistant, and then again start the IV crystalline. And that is a solution of 150 milliliter per hour. Slowly, you have to give, monitor the vital sign. And especially if the hypoxia is there, you perform the positive pressure oxygen administration, and especially theophylline in 250 milligram intravenously slowly, because you are going to have the expansion of the respiratory alveoli. Theophylline will expand the alveoli contents, and this results into less drastic effect of the respiratory area. And start the basic life support. If breathing cease, transport the patient to the emergency. And if no sign of hypoxia, you are safe, you send the patient to the emergency area. Ladies and gentlemen, in aspiration, it is very important. But one thing is the removal of the foreign body. Second is the supply of the oxygen, and then to the crystalline, monitor vital sign. And if there is a more aspiration is done and it is in the lungs, especially gastric juices, you administer the theophylline so that the lung expansion is there. So after this whole, we are coming to the last medical emergencies in dentistry, that is the altered consciousness. These altered consciousness is a vasovagal syncope, which is very common in dentistry, orthostatic hypotension, seizure, local anesthesia toxicity, diabetes mellitus, thyroid dysfunction, adrenal insufficiency, cerebrovascular compromise. So just vasovagal attack, you see sudden transient loss of the consciousness occurs secondary to the period of cerebral ischemia. Patient at once is reporting to you with stress and anxiety. That results into release of catecholamine, epinephrine, and norepinephrine, which is resulting into change of the tissue perfume, decreases the peripheral vascular resistance, and decrease the blood flow, and that is peripheral pooling of the blood, resulting into all the blood. It is pooled in the legs and the distant organs, and that results into decrease in the circulatory volume and decrease in the cerebral flow, resulting into syncope. That is the phenomena how the syncope is used to occur. So for that purpose, that results into the compensatory blood pressure, and especially your brain supply to the area, especially to oxygen and nutrition is reduced. Now, predisposing factor to syncope are psychogenic and non-psychogenic. In psychogenic fright, especially the surgery frightness, that if you ask the patient that we are going to take much time in your the impaction remover, then there is fright. Then is anxiety, emotional stresses, especially I have asked that when the area of the clinic, if it is not pleasing one, unwelcome news that oh, the instrument broken, yeah, it is anything related to the anxiety, sight of the blood or the surgical dental instrument. If the patient, you are giving visibility to all to your surgical instrument, and especially when you are taking the knives and syringes in front of the eye of the patient, it becomes very psychogenic, and that results into syncope. Non-psychogenic, when the patient is sitting for an upright position for a long time, especially in the waiting room, and patient is standing in the waiting room for a long time, patient is hungry, exhaustion, and poor physical condition, especially male people, they used to stand very much in the waiting rooms as compared to sitting. Hot, humid, and crowded environment, and a patient, especially below to the 16 and 30, 60 to 35, that is especially in between these two ages, 16 to 35. These are not the older people generally get the syncope. It is the especially with reference to the young people, and they get the syncope. This is the proper position of the patient right here on my right side. Then that is the upright position that should not be done, in especially when there is syncope. And you, that is called when the question of the person said that what is the Tenderberg position. This is the Tenderberg position with the person on my right side. That is the Tenderberg position. Relief of anxiety is the just to recognize the anxiety in very early stages, and especially when you take the questionnaire in black and white, you will come to know that this medical history relieves that the patient is very anxious and excited. These are the clinical manifestation of the syncope: pre-syncope, syncope, and post-syncope. Now, these are the three parameters you must understand for the syncope patient. What is pre-syncope? These are the, yet the syncope is not there, but the symptom starts. Patient reports to feeling of warmth, getting pale, and loss of the pinkish color, grayish color tone, heavy perspiration, especially complaints of the feeling of the bad pain, nausea, blood pressure approximately at the baseline, and there is more tachycardia. This is yet the syncope is near, but as soon as the late symptoms appear, especially pupillary dilation, patients start yawning, hypopnea, and coldness in the hands and feet. Patient has the hypotension, then tachycardia, reverse to the bradycardia. Patient starts saying that I have visual disturbances, and certainly leading to the loss of the consciousness. This is the pre-syncope symptom. When the syncope appears, you are going to manage it. Terminate all the dental treatment. Position patient in spine position with the leg raised above the level of the head. That is called tenderable position. Attempt to calm the patient, have the good conversation with the patient, place the cool towel on the patient's forehead so the temperature is slightly lessened, and monitor the vital sign. Throughout the syncope episode, terminate all the dental treatment, position the patient in spine position, leg raised, and especially above the level of the head, so the vascular supply to the brain is increased. Check the breathing. If the absent, start BLS without any delay. Call the medical assistant, and also consider etiology of hypoglycemia, CVA, or cardiac dysrhythmia. Don't just think that it is only the ischemia, it is only due to syncope. You must understand that it may be due to hypoglycemia, or maybe CVA or cardiac dysrhythmia. But if the breathing is absent, but then you have to go for the BLS. If it is present, then ammonia ampule should be crushed and it should be inhaled. This is very important. This is a respiratory irritant. It increases the respiratory mechanism. Monitor the vital sign, and patient should be escorted to home. Sorry. Anxiety control measurements should be done in very initial stages, especially a patient which has the history of anxiety in your initial stages. And that is the ammonia inhalant. You just crush it and you are going to have the relief soon if the syncope patient is definitely diagnosed. Then orthostatic hypotension, that is the significant reduction of the blood pressure upon standing, and more common in elderly. When you are standing for a long time, sometimes the blood pressure is, there is pooling of the blood in the lower extremity, there is hypoxia of the brain, and patients used to fall down. That is especially guardmen people, all the guards, they used to have a sometime this, and that's why the mandible is fractured, and we are used to guard it as the guardman fracture when there is symphysis fracture and the fracture on the biside of the condyle. Disorder when the sympathetic neuron do not release norepinephrine and approximately resulting into impaired vasoconstriction, resulting into lack of vascular supply to the brain. Side effect of the medication to the variation mechanism, including especially peripheral vasodilation, autonomic dysfunction, and volume and depletion. These things actually results into peripheral pooling of the blood, which is basically a orthostatic hypotension. These are the different medication, especially starting from the alcohol up to the vasodilators. These all drugs are capable of producing the orthostatic hypotension when the patient is taking all these drugs. Now, these are the symptoms: generalized weakness, then dizziness and light headache, then visual blurring and darkening as a visual field the patient used to feel. The severe cases, loss of the consciousness like syncope, other system, fatigue and congested swallowing, slow swallowing. The patient generally used to report as a neck pain and headache localized, especially into suboccipital, posterior cervical or shoulder region. And that is the general terms as the coat hanger headache. And it is more than 50% these patients used to prefer this generalized weakness and dizziness and visual disturbances. And these all are the symptoms of the cerebral hypertension. What you are going to manage it? Just terminate all the dental treatment, position the patient in spine position, leg raised above the level of the head, monitor vital sign. Once the blood pressure improves, slowly return the patient to sitting position, monitor vital sign, and discharge the patient to home and obtain the medical consultation before any further treatment. That is very important, that do not proceed without the medical consultation. Seizure is another thing. These are two types of seizure, either idiopathic and either it is symptomatic. Especially when you are idiopathic, these patients are not easy to demonstrable region of the brain, and frequently it is generic origin. By the symptomatic, the condition is associated with the pathology of the brain. There must be any anomaly of the malformation in the brain, injury, or maybe having the patient other symptom associated with the etiology with reference to fever, hypoxia, or hypocalcemia. And these results in specially to the patient and get at once the epileptic seizure attack. Oral manifestation of these patients are the soft tissue laceration of the tongue and buccal mucosa, because these patients used to go for the episode of seizure. Facial fracture, they may report to you. Trauma to the teeth, subluxation of the TMJ is very common in these patients. Injury to the drug therapy, especially when they are taking and gingival hyperplasia due to taking of the phenytoin, sodium, especially these patients used to take the antileptic drugs, and recurrent apathies like ulceration due to a lack of diet and immunocompromised status, sometimes anomalies of the dental development, especially taking of drugs and all these things, and maybe sometime in syndromic in nature, and cervical lymphadenopathy due to repeated attacks of the infection and trauma. That is the one thing very important. It's isolate the scissor. Tonic chronic movement of the trunk and extremities is there. Loss of consciousness is there, and especially patient vomiting, airway obstruction, and especially loss of anal and urinary control. And patient, you are going to terminate all the dental treatment, position the patient in spine position, and all the subject near to the patient should be removed. If the patient is unconscious, call for the medical assistant, place the patient on one side. That I just going to tell you that how you are going to place the patient on one side. Suction the airway, start base BLS, monitor vital sign, administer oxygen. When the patient is unconscious, transport the patient to the emergency room. If the patient is conscious, suction the airway. If necessary, monitor vital sign, administer oxygen, consult physician, and observe the patient in the office for 1 hour. Have the patient consent that to go home, and that is the better thing, that do not perform the dental treatment and postpone it to next time. Now, I just give you one presentation that if the patient repeat or sustain scissor, what you are going to go, you are going to introduce the diazepam. Now, this is just a question any person asks again, that you are going to relax the person, and that is better that you go IV up to 10 milligram, and you are going to have the relaxation of the patient. You can give midazolam, and that is 3 milligram per minute, IV or intramuscular, to 6 units till the seizure stops. Call someone for the summon medical assistant, and especially protect the patient from the nearby object. When the seizure is ceased, place the patient on one side, suction the airway, start BLS, and monitor violence, administer oxygen if nearby, and transport the patient to the emergency room. Ladies and gentlemen, I have just going to place one videos to you. Just this scissors used to appear not only in the area of the dentistry, but you can face this emergency on roadside as well. So for the dental surgeon, they must be aware how to control the seizure. And before going, you must understand the seizure and syncope difference. The upright position in syncope, the seizure can appear in any position. Pallor persists, but there is no pallor in seizure. Patient blood supplies is right there. Unconscious seconds, and this patient in seizure remain unconscious for minutes and hours. Recovery rapid, but in seizure the recovery is not rapid. It is very slow. Injury is uncommon in syncope, but in case of seizure, the injury is very common. Tongue biting is never present in the syncope, but tongue present is very common in the tongue biting. But the post-ischal confusion, MGA, and headache, that is always absent in syncope, but in the case of seizure, it is always present too, because this whole related to the internal brain problem. So this is the, you look at this, baby is going to get the seizure. Relax.
Don't panic, just move back. Move any potentially harmful object out of harm's way to prevent injury. Do not restrain the person and give him or her head support. After the seizure ends, move the person onto the side. Tilt his or her head back to protect against choking from possible vomiting. How to give emergency medical aid to seizure patients. Move any potentially harmful objects out of harm's way to prevent injury. Do not restrain him or her from moving. Provide head support and wait for the attack to end. After the seizure attack eases, move the person onto the side and tilt his or her head back to prevent choking.
Thank you. That is actually required when you are at anywhere in the street. But if it is in the dental clinic, you are going to. We were managing the seizure, and we have just covered it, and now this is
If you suspect someone is having a seizure, it's important to protect them from harming themselves during the fit. Clear away any potential dangerous objects like hot drinks or sharp objects. Don't restrain or move them. Make a note of the time when the seizure started and how long it lasts. Protect their head by placing something soft underneath or around it, like a towel, and loosen any clothing around their neck. Once the seizure has stopped, open their airway and check their breathing. If they're breathing, put them into the recovery position. If they stop breathing at any point, prepare to treat someone who is unresponsive and not breathing, monitoring their level of response.
For the person who have just joined,
if you suspect someone is having a seizure, it's important to protect them from harming themselves during the fit. Clear away any potential dangerous objects like hot drinks or sharp objects. Don't restrain or move them. Make a note of the time when the seizure started and how long it lasts. Protect the head by placing something soft underneath or around it, like a towel, and loosen any clothing around their neck. Once the seizure has stopped, open their airway and check their breathing. If they're breathing, put them into the recovery position.
जी सर
मैंने कहा वेटिंग में काफी लोग हैं वेटिंग में
If they stop breathing at any point, prepare to treat someone who is unresponsive and not breathing, monitoring their level of response.
No, that is the actually required things. And if we go for the summary, that is the first, yet you take this arm on one side, then you put the straight the leg up, then you tilt the leg and you place the head on beneath the above area, and that is the position which you are going to have after the seizure is over. These are the 4 steps which you have to manage, which has been also described during video. Now, local anesthetic toxicity, that is also very common. That is entirely depends upon the what type of the local anesthesia you have given and what is the concentration of the local anesthesia in the blood. Dose of the drug administered, how many ampules you have given, rate of absorption, how speedy it has taken to the body, site of injection, whether there is any vascular area, or say if you inject in the hemangioma or any vascular area, vasoactivity of the drug, how much it is promptly absorbed, and especially that you have used the vasoconstrictor or not. If you have not used, then it is going to cause more systemic toxicity. And biotransformation and elimination is there or not, and if the patient has any systemic problem, especially for elimination, you are going to get the more problem. Now, rate of absorption, drug injected rapidly in a bolus has high local anesthesia plasma concentration, and site of injection, especially more vascular tissue, poses the risk of systemic toxicity. These two things should be remembered very nicely, that is rate of absorption and site of injection. These are the different maximum doses local anesthetic agent which I have just placed there. Generally, we used to use the lignocaine, and that is the you can use up to 10 cartridges of the 1.58 ml cartridge. That is the maximum you can do. And other, it is a titocaine, bupivacaine, mepivacaine. These are things, it is written there, and you have to abide by the maximum dose per milligram per kg. We are going to get three types of toxicity of the local anesthesia: mild, moderate, or severe. In case of mild toxicity, the patient is very talkative, having anxiety and slurred speech, confusion. This is mild toxicity. Stop administration of the local anesthesia at once, monitor vital sign, observe the office for 1 hour, that he is absolutely normal, and then consult the patient. And you are going to have the dental care. In case of moderate, speech is slurred, but the tremor starts. There's headache, patient complaining of dizziness, blurred vision, and patient goes to drowsiness. Stop the local anesthesia, place in spine position so that the blood supply to the brain is increased, monitor the vital sign, administer the oxygen, and observe in the first affair, and do not perform further any dental procedure. Now, the severity of the toxicity is, that is the patient starts seizures, cardiac arrhythmia, or sometimes it may lead to arrest. This arrest is a really challenging one, because you have to go for the clear-cut differential diagnosis that what the problems you are getting. Place the patient in spine position, then it is very important the section of the oral cavity. If the patient has the vomiting, call for the assistant, monitor all the vital sign, administer oxygen, start into IV line should be administered, and especially inject the diazepam and medetomidine. Already we have discussed in detail. Is go for the BLS if necessary, observe the office in 1 hour, and transport the patient to the emergency care if the patient do not recover in 1 hour. The diabetes mellitus, characterized by the persistent increase of blood glucose level and results of the absolute relative deficiency of insulin. What are the protocols for the dental appointment? Number 1, appointment should be early appointment, pre-medication, local anesthesia, treatment procedure, and patient assessment. These are all the important protocols for the diabetic patient, and you have to abide by the obeying. Hypoglycemia is the more aggressive situation, especially a patient who is on insulin dependent. Because the glucose is the main energy source, this hypoglycemia is not considered as the disease, but it is a result of the underlying issue and combination of them. That is, either you have taken the more insulin, either you have not taken the glucose or carbohydrate, and that resulted into hypoglycemia. In hypoglycemia, you have to get the recovery as soon as you can, because this hypoglycemia may result into more damage of the brain. The acute hypoglycemia, the patient reports to you with mild hunger, nausea, and mood change and weakness. This is the mild. Then moderate, the patient anxiety exaggerates. Then patient had confusion, uncooperative patient, paler, and then there is more tachycardia used to appear. In severe cases, patient become unconscious, hypotension and seizure may appear, and that is very life-threatening as well. How you are going to manage hypoglycemia? Number one, terminate all the dental treatment. See the sign of the hypoglycemia. If it is mild, administer the glucose because the patient is conscious, sugar or fruit by mouth, monitor vital signs, and do not do any dental care. Just get the consent of the patient and whether of the physician, especially if they are unsure. You must have to monitor why the hypoglycemia has occurred. If the moderate, you are going to give orally glucose source because the patient is conscious, vital signs, and then you can give 50 ml of 50% glucose or the intramuscular injection of the 1 milligram glucagon. That is, if the severity is more, you can go for the IV, and if it is routine, you can go for intramuscular and go for the consent of the physician. If it is more severe, then you are going to give the same intramuscular or intravenous glucagon, administer the 50 ml of the 50% glucose. Then you call the medical emergency, monitor the vital sign, administer oxygen, and transport the patient to the emergency area. That is the management of hypoglycemia. The thyroid dysfunction generally either hypothyroidism or hyperthyroidism. In hypothyroidism, it may result into by the infection, psychogenic problem, narcotic, especially barbiturate and tranquilizer intake, any cardiovascular disease, especially bleeding disorders, especially with reference to congenital bleeding disorder, mixed edema and coma. Now, these hypothyroidism patients are managed in emergency, that these used to get the thyroid storm, and especially not the thyroid storm, these are the deficiency of the hypothyroid, and it is called the mixed edema coma. And this is a rare but life-threatening condition. In the hypothyroidism, the people used to get the emergency, you have to report them as soon as you have the sign and symptom of hypothyroidism, you refer it to emergency room. Therefore, at the treatment, call for the medical assistant, administer oxygen, monitor vital sign, start intravenous fluid, and electrolyte replacement, especially glyceride, is very important. Thyroid hormone are usually administered through a vein, intravenous or muscularly very less. To quickly correct the low thyroid hormones level. But I will recommend that if you are a dental surgeon and you are not capable of the monitoring the hypothyroidism, it is better that you go for the steroid and adrenal cortical hormone as compared to the thyroid hormone. That will be more promising for you. In hyperthyroidism, the thyroid storms used to appear, which I was talking, and this is a very exciting patient, and especially if the patient has not taken especially the thyroxine, and the patient is very conscious regarding the dental treatment, and the patient comes to you, that you will monitor the heart rate, blood pressure, and body temperature, and you will see that these all things are very high in thyroid storms. In abdominal cardiac hyperexia of the patient has more fever, nausea, vomiting, nervous, palpitation, tachycardia, tremor, weakness. These are all the manifestation of thyroid storm. You people are well aware of it. And when there is thyroid storm, you are going to manage it like this. Terminate all the dental treatment, call the medical assistants, oxygen, vital the monitor sign, initiate the basic life support, start the intravenous line drip of crystalline solution, and transport the patient to the emergency facility. These all things which I am mentioning again and again are the basic parameter for all the emergency which are occurring in the dental clinic. Adrenal insufficiency, especially when we are talking of the adrenal gland, these are the specially steroid hormones. Either the patient is taking the steroid hormone, that's why the patient is deficient of the adrenal insufficiency. If the patient is taking the steroid, you have to double the dose of the adrenal patient, especially patient in under the steroid. Especially these people suffer with the regulation of the sodium conversion, potassium secretion, and water retention. That is why these people has the edema and the other problems, especially with the chest as well. The adrenal insufficiency causes are especially the cancer of the adrenal gland, surgical removal of the adrenals, bleeding into adrenal gland, that is space of occupying a lesion, especially when the genetic disorders, patient with the autoimmune disease like Addison disease, and these actually results into the fighting of the immune system to the adrenal gland, resulting into lytic activity of the adrenals. Adrenal insufficiency caused by taking of exogenous corticosteroid is the commonest, which I have already discussed, that if you are taking the steroid due to any disease like uncontrolled asthma, like rheumatism, or any transplantation, you are going to have the corticosteroid, then you are going to get the double dose before getting any dental treatment. These are the insufficient patient sign and symptom: abdominal pain, confusion, feeling of extreme fatigue, hypotension, myalgia, nausea, loss of consciousness, weakness. These are sometimes associated with the severe acute adrenal. Now, how you are going to manage, terminate all the treatment? Patient in spine position, have the common medical assistant giving the corticosteroids, especially 100 milligram of hydrocortisone. You can give intramuscular, intravenous, oxygen, monitor the vital sign, and IV line, especially dip of the crystalline. Basic line spool and transport the patient to the emergency. Ladies and gentlemen, look at this whole treatment. You will see that these all things are all very, very common in all the emergencies which are appearing in the dental department. So these all things, these 9 steps which I have mentioned, especially with acute adrenal, these are generally very common in every dental treatment. Now, lastly, we are going to cover the cerebrovascular compromised patient. These are the list of the cardiovascular diseases: hypertension, coronary disease, myocardial infarction, coronary syndrome, rheumatoid heart diseases, cardiac arrhythmia, angina, stroke, and genital cardiovascular diseases, and congested heart failure. And for that purpose, you are have to see that especially these patients with a cardiovascular compromise have the cerebral flow altered, and these are embolism of the particular matter for the distinct side and reaching to the brain, formation of thrombus in the cerebral vessels, and that is also life-threatening, or the rupture of the vessel resulting into the brain hemorrhage. Now, manifestation of cerebrovascular compromise, that is the headache that range from mild to the worst patient ever experienced, unilateral weakness of the paralysis of extremities, especially facial muscle or both, slurring of speech, difficulty in breathing and swallowing, loss of bladder and bowel control like seizure, and visual disturbance, dizziness, and partial and sometimes the total loss of the consciousness. For these patients, same parameters you are going to do, that is, you are going to terminate all the dental treatment, someone to for medical assistant, patient in spine position, slightly raise legs, monitor or the Voltaire sign, BLS, and then patient support to the emergency care. Ladies and gentlemen, these are very, very common things which I have repeated again, and again. These are the termination of all the dental medicine, has someone count to the medical assistant, spine position except cardiac and respiratory people. You are not going to have the spine position, that is 45 degree. You are going to administer oxygen approximately in every patient except to the hyperventilated area. Then you have the concept of the BLS, you have the concept of the crystalline IV line, and you have the concept of the steroid intravenous given, and especially you are going to refer the patient to the emergency room if it is under control. Ladies and gentlemen, I am very much thankful to you that you have very patiently listened to this whole quite long, what you say, talk of the, and now I'm there. You like to have any question?
So guys, if you have any question, you can ask Dr. Arshad Malik, Professor Dr. Arshad Malik. Sir, thank you very much. First of all, on completing this topic, it was a very great topic and a great presentation by you, and it was much needed of our, because as a graduate as well as a house officer, I also felt this topic is the one जिस पे बात करनी चाहिए हम सबको. तो सर, अच्छी बात है कि माशाल्लाह आपने बड़ा अच्छा टाइम भी निकाला रोजे की हालत में, और 2 घंटे आपने बड़ा अच्छा एक सेशन किया हमारे साथ वेबिनार. तो थैंक यू सर अगेन. एंड सर, अगर किसी का कोई क्वेश्चन है तो लाइक ही और शी कैन आस्क सर राइट नाउ. ठीक है, बेसिक माइक म्यूट भी कर दें. ठीक है. So
I can see the very small children's as well, that they are taking the lecture of the dental emergencies. And I think that it is a good fun.
So coming back, if anyone has question, you can ask. And about the certificate, it will be provided to you in just 1 week. after like signing from the sir and ICD. Thank you again for attending this lecture. And soon, inshallah, we will be back with another some webinars as well. ठीक है sir. Thank you very much sir. खुदा हाफिज़. क्या रखिएगा.
Thank you very much, everyone, for patient. It's a long seminar because it used to cover 2-3 hours, and Alhamdulillah, there are few person. I think these 20 participants. I do have all the respect to them that they have a very patiently listened to my whole presentation, and thank you very much to the DICE as well, and to the International College of Dentists that they have given me the opportunity to give this presentation. Thank you very much, everyone.
Thank you sir. खुदा